This is another session of studying for the PMHNP exam. I'm using the purple book, Review and Resource Manual, Psychiatric-Mental Health Nurse Practitioner 4th edition. It's by ANA Enterprise, by Kathryn Johnson and Don Vanderhoef. So this is the table of contents that I'm going to be summarizing from the book. We're going to start off with depression, bipolar, anxiety, OCD, PTSD, schizophrenia spectrum, delirium, dementia, SUD, personality disorders, children and adolescents, and then other. So this is the depression so far. It has some information. I'm just going to go slow here. If you want to pause the video. These are very condensed notes from the purple book. I'm not using the yellow book, even though I do have it, but I think I want to do the purple book first and use the yellow book for the questions, because it does have a lot of questions, which I love. But the purple book, I think I'm going to do this one first and go through these first. And then there's, of course, the antidepressants, all the antidepressants. All of them. Of course, there's a lot of medications, and we need to know a little bit of every med, the main things. Serotonin syndrome, antidepressant discontinuation syndrome. That's it for depression. And then bipolar now, this is what I'm working on at the moment. So in order to understand bipolar, you need to understand mania and hypomania. That way you can know if the patient is bipolar 1 or bipolar 2, and also whether they're rapid cycling or not. So this is where I stopped so far. All right. So patient assessment. All right. And then we have medications that mimic manic. So I think a question can be asked here in the test. If a patient is showing all these signs of mania, but then they're on one of these medications, I think they will be trying to tell us, they want us to use that as a possible differential diagnosis or possible reason why the patient's having mania out of nowhere. Hydralazine. Oh no, I didn't know hydralazine would cause that. All right. So captopril, that's an ACE inhibitor for hypertension. Cimetidine, that's a H2 receptor antagonist. It's for GERD. Okay. And corticosteroid, we know those already. Cyclosporine, that's an immunosuppressant. Prevent organ transplant rejection. Disulfiram, this is your antabuse. The other name for it is antabuse, and it's for used for alcohol abuse. Well, to treat alcohol abuse, pretty much. Hydralazine, of course, blood pressure, hypertension. Isoniazid, that's the TB medications. Okay. Whoops, can't type. Okay. Now also, mania can be triggered by antidepressants, talked about that before, ECT, light therapy. Okay, so that's the main thing about this. When you're treating depression with antidepressant, you have to rule out bipolar. You cannot prescribe these antidepressants to people with bipolar because it will trigger them to have manic episode. So just be careful about that. I know I wrote that somewhere here. Right, so MDD, if you want to diagnose someone with MDD, they cannot have manic, hypomanic episodes, none of that. They cannot have these things. Because if they do, that means they're not MDD. They're not major depressive disorder. They have to fall under the bipolar disorder, okay? And their bipolar patients are not treated with antidepressant. They are treated with mood stabilizers, okay? Now, another thing we gotta know here is we gotta rule out any conditions that might be contributing to the symptoms. Assess the identity of the client, level of acuity, severity, duration. So part of the assessment should include assessing the patient, severity of symptoms, duration, and level of acuity. Why? Because here we're trying to determine, are we admitting them to the hospital or are we going to treat them in the community, okay? Admit to hospital or treat as outpatient. This is an important decision to make when someone has bipolar. So you have to hospitalize when there is safety concern. Safety is everything in psych. To ensure adherence to medications and to rapidly stabilize on medications. That makes sense, okay? If it's not acute, they can be treated in the community. That's fine. All right, now treatment. Okay. So number one, you know we're going to be talking about lithium. It is the gold standard. You need to know that for bipolar. Okay. Treat manic episode. That's important. It has evidence of anti-suicidal effects. All right, and then it does have clinically, it's just have a lot of side effects, okay? It's not stupid autocorrect. DZ means disease, by the way, or DX is disorder. Anyway, what does it do? Now, I don't know where to even begin. It's a lot. It messes up everything. It really does. So, oh God, where to begin? Okay, first of all, it messes up your thyroid. Weight gain. Okay. Actually, weight gain is not that important compared to... All right, we got fine hand tremors. Okay. Mental cloudiness. Diabetes insipidus. Isn't that crazy? Because think about it. It's behaving like a salt in the body. Of course, it's going to cause GI upset. In fact, everything causes GI upset. So I don't even want to write that down. But also it causes dysrhythmia. Think about it. Salt and T-wave inversion. This is kind of important. And then weight gain and leukocytosis. Okay, so you need to know lithium side effects. because I'm sure there's contraindications. Not everyone can take it. If someone already has dysrhythmia in their heart, they're not going to just take lithium, you know. And now the other thing you need to know, where am I? The other thing you need to know is therapeutic level, of course. This number you do have to know. And more than 102 is toxic levels. Okay? Okay. Take baseline labs before starting lithium. You can't just start lithium, okay? You need everything. You need thyroid panel, serum, creatinine, BON creatinine. We're checking the kidney, right? Pregnancy tests, that would be important. An ECG if patient older than 50. Okay. If patient is rapid cycling, they will need lithium plus something else. Not just lithium, okay? And of course, you're going to educate your patients about the side effect of lithium, okay? So, I'm doing the treatment in blue. So lithium, you really need to know these things. I know there will be a question about lithium. That's for sure. All right, and then we're going to talk about anticonvulsant medications, aka mood stabilizers, okay? Of course, lithium is also a mood stabilizer, but anything, these anticonvulsants are used as mood stabilizers for bipolar patients. So we're going to do carbamazepine. Okay. Don't forget your black box warning. We got agranulocytosis and aplastic anemia. Okay, so what do we need to check? CBC before starting. Okay. You see what I mean? And after to monitor. Because these two are very serious. Agranulocytosis and aplastic anemia. These are very serious side effects. So you have to make sure the patient doesn't have those problems already. So you check the CBC before starting it, and then you start checking it after to monitor. Then we have valproic acid. I don't know why they keep putting these together. Confusing me. Valproic acid is depakine. Okay. Yeah, these two medications confuse me a lot. So you have valproic acid. The brand name of it is depakine, and Divaplorex sodium, the fancy name is Depakote. I mean, the brand name is Depakote. Okay, I'm gonna put them together because although they're two different medications, but they behave the same. Okay, they increase the valproate in the system. Both affect the liver harshly. Let's just say both harsh on the liver. So check LFTs. Okay, you need your liver enzymes checked for both of these. And I guess Depakote is less GI effect. Okay. Depakote has less GI side effects. Okay, that's like probably the difference. Of course, they're going to cause nausea and vomiting and diarrhea. I don't even write this down because everything causes nausea and vomiting and diarrhea. So I don't know. Okay, so now carbamazepine. Are we checking liver for that too? One second. So yes, even carbamazepine, we have to check. It's also harsh on the liver. check LFTs before prescribing. So these are not random medications you can just prescribe. You have to get blood work. You have to see how the blood work look like. And then based on that, you see if you weigh the benefit versus the risk, right? Let's say the manic episode is causing the patient to compromise. It's compromising their safety. So in that case, we check their liver, we check their CBCs, and we see which medication we can order for them. All right, the next one is lamotrigine, which is Lamictal. All right, this one now, you gotta know the side effect is Stevens-Johnson syndrome. Remember this from nursing school? Yep, same thing. Stevens-Johnson syndrome. Why is Stevens-Johnson syndrome a big deal? Because it's actually slouching of the skin, and the patient will end up in the burn unit. You know, it's not just like a little rash. So slouching of the skin, life-threatening burn unit. Okay, it's serious. It's not just like a inconvenience. It's actually dangerous. All right, so moving on here, let me see. CBC, blah, blah, blah. All right, lamotrigine. Now, lamotrigine is indicated for maintenance only. Of course, you have to titrate slow. I think they're all you have to titrate slow, you know. May increase metabolism. Okay, often used in combination with lithium and general. So it says lamotrigine is often used in combination with lithium and second-generation antipsychotic and antidepressants. Wow, interesting. I didn't know you can order all that. Well, apparently it does have hepatotoxicity too. It's not a black box warning, but it can also cause hepatotoxicity. So you see the trend here. Every time you're ordering lithium, you got to think about the kidneys. Where is it? Side effect. The thyroid and the kidneys. Okay, and the ECG. All right. Before ordering anticonvulsants, you're going to think about, for carbamazepine, you're going to think about CBC. And then for the rest, you're going to think about LFTs, okay? Now watch here. We have something else to add under lithium, which is lithium drug interaction. Okay, it interact with, of course, it's going to interact with a lot of stuff because, wait, how does it cause impair thyroid? Wait, will it increase my thyroid or decrease my thyroid? Oh my gosh. Okay. Lithium toxicity side effects, signs and symptoms. We have slurred speech. Oops. Confusion, and then you have severe GI upset. That means your body is having very high level of lithium, which you shouldn't get to this point if you're monitoring your patient's lithium levels regularly. So no one should get to this point, right? Now here it's saying risk for hypothyroidism. So wait a second, blah, 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 evidence. By the way, oh, there it is. Impaired thyroid. So all it says is impaired thyroid functioning, but then in the next page it says risk for hypothyroidism. Okay. So then here you can just put hypothyroidism. Okay, because just writing that it affects thyroid is not very helpful. Yes, so hypothyroidism because it interferes with the liver enzymes. I mean, with the thyroid levels. All right, I think that's about it when it comes to these meds. Oh, what was I doing? Lithium interact with NSAIDs, ACE inhibitors. Okay. So it says they can double lithium levels. That's not good at all, right? All right, that's it. And we're not giving this to pregnant women, okay? No pregnancy for that. Avoid pregnancy, especially first trimester. Okay, I'm just gonna put, this is just gonna be a no for pregnancy, so. All right, so now I have another document, let me find it here, that I was putting in there all the psych medications pretty much. So I did go through this, obviously, because I study all the time. Anyway, so I started here, wrote some information about it. So the gold standard, reduced suicide, therapeutic lithium. I don't know why this number is different. Like, can we just agree on one number? So we're not making this too complicated. I like the 0.6 to 1.2 because it's easier to remember. I don't know why. It's just... All right, therapeutic level, blah, blah, blah. So here it says more than 1.2 is toxic. See, this is why I use two different sources to study for the same exam. You got to use one. So anyway, I'm going to go with the purple book. The purple book is saying 1.2 is the toxic. Anything above 1.2 is toxic. So I'm not doing that. And of course, the fancy name for lithium is Iskallith. Iskallith. Sounds like a Greek god. Iskallith, you know, from the Odyssey or something. Anyway, blah, blah, blah. See here, it doesn't even say slurred speech. So I don't like this. I don't know where I got this information from. But I don't like that. I'm going to stick with my purple book. Of course, you're going to avoid in renal disease. And look at this. You're going to avoid in severe dehydration. Because I think it's only going to deplete your sodium. So, where do I put that? All right, avoid in if patient is severely dehydrated. Okay. We're not going to cause more harm, right? Okay, moving on. Let me see what else I wrote here. All right, here, yes, I did put, look at that, pancreatitis. The purple book didn't say anything about pancreatitis. So this was my way of remembering which one is Devalproex and which one is valproic acid. So I said Depakote is the Devo. Yeah. So that way you remember the Depakote starts with the Diva Plorex, so you don't confuse Depakote with valproic acid. So anyway. So see here, this is not accurate because it turns out both of these causes liver. What about pancreatitis though? Let's look it up. So yes, apparently they both cause pancreatitis. See what I mean? Like sometimes these books don't have all the information. Okay, once I'm done here, I'm getting rid of... Okay, and then these are the other two. So Tegretol. Tegretol, that's the fancy name for carbamazepine. I don't know why I have to know... I mean, obviously, I do have to know the generic and the brand for work, for real life, because a lot of patients might be saying, oh, I'm on Tegretol, but in my brain I might forget that it's carbamazepine, you know what I mean? So I do want to know both, but in the exam I think it's only generic. I think. I don't know. I haven't looked that up yet. I'm trying not to distract myself, but I keep, every time I write a medication, I write the generic and the brand, because this notes right here is what I'm going to use to study for everything. And I'm going to use these notes one day, like if I'm taking care of my patient and they're saying something and I want to look something up really quick that I know it's on here, so I can always search up either this name or this name. I don't want to be stuck not knowing the brand and the generic, you know, that's not right. I need to know. So I'm just going to study both of them at the same time. Anyway, anticonvulsants, done with that. See, this is a little bit, oh, I know where I got these from. This is from the pharmacology section, the psychopharmacology section from the purple book. Okay. Okay. All right. And also this was part of the lecture from class, from the course. So see here, it's all mumble jumbled together. This was interesting though. It has all of the receptors. I'll leave this here if you guys want to. So D2, that's your dopamine, right? What happens if it's on and what happens when it's off, you know? And this is 5-HT1A, which is the, it's so hard to remember these numbers. So I just call it the calming receptor. So when you turn it on, the patient becomes calm. That's buspirone. These are not the same ones. This is number 1. This is the calm. Number 2 is the psychosis one. So when you turn it on, is psychosis and hallucination will be observed in the patient. When you turn the 2 off, less psychosis, less hallucination. A1 and A2, A1 and A2, of course, these are vasoconstriction and vasodilation, and these two are for norepinephrine, but I add them here because don't forget that some antipsychotic medications, not antipsychotic, antidepressants, some SNRI, they work on serotonin and norepinephrine. So this is important because they use these receptors, just to kind of have an idea. But anyway, H1, and when it's on, it awakes. H1, when it's off, it makes you go to sleep and gain weight. M1, when it's on, it makes you have saliva and more peeing, more pooping. M1, if it's off, it causes the opposite. So you have dry mouth, you can't go to the bathroom, you know, you can't pee, you can't poop. So this has like, I do like these receptors, so I do want to keep those. Anyway, we'll come back to this later. So this is my, what else do I have to write about bipolar? Oh my gosh. Okay, Stephen Johnson. And look at that. You gotta draw labs 1 week after starting anticonvulsants, okay? And redraw labs 1 week after starting. Okay, blah, blah, blah. Redraw labs 1 week after starting. Okay. Got it. Something about lithium that I didn't put. When do you draw serum? When do you draw lithium? When do you draw lithium level? All right, you draw lithium level. Okay, you draw serum lithium at trough level, which is 12 hours post-dose. This is kind of important. So once the patient gets the dose, we used to do that in the hospital. Once they get their dose in the morning, we come as night shift and we draw their the trough level. Okay. Moving on. What else do you guys want me to know? Okay. Clinical management. And Stevens-Johnson syndrome can also cause facial tongue swelling, in case you want to know about this. So facial tongue, because they might mention this in the test, like the beginning signs of Stevens-Johnson. Now, other things to consider for bipolar patients. This is the medications, okay. Other things to consider here. You assess their safety. You assess how severe is the symptoms, what's the duration, what's the level of acuity, and then you think, am I admitting them or not? Then for acute manic patients, assess nutrition, because these people are not eating. Assess sleep, rest cycle, because these people don't even sleep. You can die. And of course, monitor for safety, because in their mind everything's great and they're having a blast. Like they don't sleep, they don't eat, you know. For non-acute manic patients, these, now we know they have mania, they have bipolar, but at the moment they're not in the manic episode. So in this case, that's when you suggest therapy. Okay. Behavioral interpersonal. Okay. Behavioral therapy, interpersonal therapy. So this is when you're going to suggest these things, because now they can really focus on therapy. But therapy is not efficient if the patient is in the full-on acute manic episode. All right. Another therapy here is called milieu. What the hell is this? Milieu therapy. I don't remember it from the course, the therapeutic course, but let's see. It provides structure and safety needs, socialization, interpersonal support, encourage independence. Okay, that sounds like all the therapies. Why does it have this weird name? All right, you know what? I actually looked it up, and it's not a normal therapy. It's a therapy that focuses on creating a therapeutic environment for the patient, for the manic patients. Yeah, I was looking it up here. It says, I don't know why ChatGPT gives me two answers. I'm asking one question. Why do you have to give me two answers? Anyway, it's saying psychiatric inpatient unit provides structure, safe environment where patient participate in activities, interact with peers, practice appropriate social behavior. When you hear, it says when you see something like this is, think milieu therapy. So memory to remember, milieu is the environment, is the treatment. So they change the patient environment. Rather than these here, different kind of therapy, obviously. This one, CBT, changes dysfunctional thoughts, and that's how it changes behavior and emotions. Well, first it changes emotions, then it changes behaviors. DBT, that's more for borderline personality disorders, interpersonal, it's for other things. But milieu is when the environment is therapeutic, so that's kind of interesting. All right, cool. What else do I need to know here? Blah, blah, blah. Of course, you're going to educate the patient. Oh, monitor them for STDs because they are manic, and they might be doing risky sexual behaviors. So you got to educate them about that, and then give them financial resources, because unfortunately these are the people who will go and buy so many things, expensive things that they can't even afford, you know. All right, now the last thing I want to mention here is manic signs and symptoms in adolescence. Okay, it's going to manifest a little bit different, more psychotic. They will show more psychotic episode, antisocial behavior, and it's going to have substance abuse. You know, they're younger, so it's different. And then it's going to show significant behavioral problems, okay, in school especially, and of course in real life. Follow-up for bipolar patients with these medications, you're gonna have to see them weekly, okay. Follow-up with after starting med weekly, okay. So of course lithium is a difficult one. What else? Jesus. Lithium, blah blah blah. Yeah, stay away from babies. I mean, stay away from okay, so it says when women are on lithium or Divalproex, they need to be on contraceptive because they are teratogenic, which means they will make the woman make babies that are scary looking, scary stuff. So lithium and Dival, okay. Teratogenic. Okay. Well, not really just birth control. They have to be on contraceptive. I can't spell this word. Teratogenic. Okay, teratogenic. You know, it's one of those words, you know, like you recognize it when you see it on the test. You know what this means. We've studied it in nursing school. But then when you start to write it or say it, it sounds so hard to, it's so hard to say. And of course, we talked about routine labs, CBC, renal, functional, thyroid, parathyroid. You were going to assess suicide every single visit, okay? Assess for suicide every visit. Every visit you're going to talk about it, even if they look fine to you, doesn't matter. And then the rating scale for mania is called YMRS, Young Mania Rating Scale. Why is it called Young Mania? Is that for children or something? Oh no, his name is Young. I'm sorry. Okay, his name is Young. All right, YMRS. All right, so the assessment tool for mania is YMRS. This is Young Mania, right, rating scale. All right, so you can use this rating scale, oh my gosh, to measure the severity of the mania. Okay, and this is actually useful when you're trying to figure out if the patient needs to be admitted or not. So let me put it right here. Okay. All right, the last section of this chapter is, I have one more thing. It's cyclothymic. Okay, cyclothymic disorder. This one is like, okay, you see how depression, or I should say MDD, really, major depressive disorder, is its own thing. And then dysthymia is its own thing. Okay, dysthymia is when you have depressed mood for 2 years. Now, bipolar is its own thing, but then cyclothymic, or cyclothymia, pretty much, to make them match. This one is also, let me tell you here. I like to read the exact diagnosis. Where are we? This book is a little bit hard to read, let me tell you. I'm just going to use my DSM. Oh, there it is. Chronic fluctuating mood disorder. All right, with symptoms. Jesus. Symptoms similar to bipolar disorder, but not as severe. It includes numerous episodes of hypomanic, mania, and dysthymic. Okay, notice it's not mania and not MDD. Okay, this is important. So these don't fit. Cyclothymia do not fit the criteria for MDD and don't fit the criteria for manic. Okay, they're really its own thing. Of course, you're going to educate, blah, blah, blah. But the big thing here is no psychotic episodes. Because if it has psychotic episode, it'll be called something else. Okay? If you're going to call something cyclothymia, the patient should not have psychotic episodes. All right? Patients, okay, this is kind of interesting. Often regarded by others as temperamental, moody, unpredictable, inconsistent, unreliable. Okay, because the tests, they might give you a case study of someone who is like that. Like a lot of his friends call him moody or unpredictable, inconsistent, unreliable. And then they'll throw in some vague, hypomanic symptoms and then vague, a little bit of whatever. It's just less than 1 week. It can't be more than 1 week, because if it's more than 1 week of manic, that is bipolar 1. That's it. Here you see bipolar 1, bipolar 2. So bipolar 1 is one or more manic episode with or without the depression. They don't have to have depression. As long as they're manic, we're going to call them bipolar 1. Okay, as long as they have one or more manic episode, in their lifetime, which is more than 1 week of this craziness right here, or anything that require hospitalization, then it is bipolar 1, unfortunately. Now, if they have one or more hypomanic, okay, hypomanic is here. It's less than 1 week, 4 days. And I think it's 4 days, but less than 1 week, More brief, not as severe, does not cause severe functional impairment. That's hypomanic. And the and is very important here, by the way. They also have to have one or more major depressive disorder episode. Then they fall under bipolar 2. All right, rapid cycling is this, but a lot, They're either manic or MDD. They're falling from manic to MDD, And then they have poor prognosis because it's harder to control. Anyway, so now cyclothymia, see how it's vague? It doesn't really match manic and does not match MDD. So it does not meet manic symptoms and does not meet MDD symptoms. Okay, it's just its own little thing. All right. I think that's the last thing I gathered from this chapter. That's it. All right. So the next chapter will be about anxiety, OCD, and PTSD.